So beginning with this first strip, if we start on this side and measure this distance, we can see that everything is pretty irregular. So we're going to say that this rhythm is irregular. Now, because it's irregular, the best way to identify the heart rate is using the 6-second method. So we can see our 6 seconds is the entire length of the strip. So we'll count the number of QRS complexes, which is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Times 10 gives us a heart rate of 140. When we look at our P wave, we can see that we don't have a P wave with every QRS, or we see that the P waves that are there look different. So this P wave here is rather sharp and pointy. It doesn't have a smooth upright curve. This one over here has a nice smooth upright curve. And over here, we have one that is slightly inverted, but almost non-existent. And here we have a very small P wave. So we can see a variety of P wave morphologies. So we're gonna say that the P wave is variable. Now, because this P wave is variable, we have a variable PR interval. And the reason for this is because the impulse is not originating from the SA node. It's originating from various areas in the atrium, and those areas that they're originating from are going to have varying distances to the AV node. So the closer that origin is to the AV node, it's going to be a shorter PR interval. And in instances when the origin is further away from the PR interval, it's from the AV node, it's going to have a longer PR interval. So here I put a measurement that it ranges from 0.08 to 0.12, but you can just put that the PR interval is variable. And then we measure our QRS complex. So I'm gonna mark my calipers there and bring it down, and I get 2 small boxes. So we have a QRS complex of 0.08 seconds. Now, because we have an irregular rhythm with a rate greater than 100 with variable P waves and a normal QRS, we can deduce that this is multifocal atrial tachycardia. So the fact that the heart rate is so fast should be a clue as to what kind of rhythm it is when you're seeing a variable P wave. With this rhythm here, we're going to start by assessing if it's regular or irregular. And so far, those are the same. This one is different. This one is different. But the rest of these are all pretty much the same. Again, they're just off by 1 small box, so that is okay. And we should even see that these are all going to be the same as each other, which they are. So we're going to say, aside from this beat here, we're going to say that this is a regular rhythm. With a regular rhythm, we're going to use the 1500 method. So using the 1500 method, I get about 17 small boxes, and we're going to have a heart rate of 88. Looking at our P waves, we can see that all of the P waves look the same with the exception of this one. So we're just going to ignore this beat for now. So these P waves all look the same, and they're all smooth and upright and rounded. So we're going to say that this is a sinus wave. So this should look familiar to everything that we reviewed in our sinus rhythm chapter. We're going to measure our PR interval. And I get 4 small boxes. So I'll zoom in for you. So 4 small boxes is a PR interval of 0.16 seconds. To measure our QRS complex, We're going to find our point at the beginning and then find the point at the end. Now, the reason that I'm picking this point is because our QRS complex doesn't completely reach that isoelectric line. So I'm just going to imagine an invisible line coming up to that point and measuring it. And so I get 2 small boxes, which gives us a QRS complex of 0.08 seconds. Now, because everything else that we see in this rhythm is regular, we have a regular rhythm with a normal heart rate and sinus P waves and a normal interval and a QRS complex, we can say that this is a normal sinus rhythm. But then we need to address this early beat here. And this early beat is considered a premature atrial complex. So basically what's happening is that the sinus node is sending out impulses, and then all of a sudden, just randomly, an impulse comes from somewhere else in the atrium just for that one beat. So it ends up being a little earlier than the normal sinus beats that are going on. So that's why it's early. And because it's having a different origin than the SA node, that's why this P wave looks a little different than all of the rest of them. But it still has a P wave with a QRS, and this is a sinus P wave, even though it looks different than the rest of these. This, because it's still upright and a normal size, we'll say that that's a sinus wave as well. But because this whole beat is early, we consider that to be a premature atrial contraction. So when you have premature atrial contractions, you want to make sure that you are identifying what the underlying rhythm. So if we ignore this beat, we want to know what is the rhythm of everything else. So we already identified that this was normal sinus rhythm with a PAC. So you need to make sure that you have both. Here is another example of sinus rhythm with PAC. So if we just ignore this area right here, we can see that all of this is regular. And using the 1500 method, we get a heart rate of 88. And we'll see that all of these P waves will look the same, and there is a P wave for every QRS. So we will call this a sinus P wave. Measuring our PR interval, we get somewhere around 0.16 seconds. And our QRS complex is going to be 0.08 seconds. So we'll say that this rhythm is a normal sinus rhythm. So if we just look at this part, normal sinus rhythm. And then we need to address what this early beat is here. So again, you can see that there is a P wave there. It looks a little different than all of the rest of them, but we have a small P wave here, and the beat is happening early. And so you can see that if I measure this regular beat here, this beat is early. So that's a premature beat. And so we will say that this is a normal sinus rhythm with premature atrial contractions, or PACs. Down below, this is another example of a sinus rhythm with PACs. And I already had it labeled for you as a PAC. But this is just another example of what a PAC can look like, because not all PACs are going to look the same, because the premature ectopic beat is going to be coming from somewhere else in the atrium, and that spot can be different with every single rhythm that you see. So you might be wondering, when you look at this early beat, you don't see a P wave. And so you might think that this can't be a sinus or an atrial, a premature atrial contraction, because we don't have a P wave. But if you look at this T wave, so the T wave that's following the QRS complex, you notice that this T wave is much taller than all of the ones before it and all of the ones after. So actually there, in this instance, there is a P wave. It's just hidden from us because it is buried within this T wave. So this is another example of what a PAC can look like. Here again are some examples of PACs. So we see that the T wave happens here, and then the P wave happens right at the end of the T wave before the T wave can return back to that isoelectric line. So this is an example of a PAC. And here's another example of a PAC. So what's happening here is that every other beat is a PAC. And so we would identify this rhythm as a normal sinus rhythm because we still have sinus P waves. And we still have a P wave with every QRS, so normal sinus rhythm. But then because the PACs are happening every other beat, we will say that this is bigeminy. So normal sinus rhythm with bigeminal PACs. The next one down. This one might be a little tricky if you just look at it rather quickly because it might look regular to you, but it is actually not regular. Because if we measure this distance here, we see that this is shorter and that this is longer. And then we have another one that's the same distance, shorter, regular, regular, shorter. So we're kind of seeing a regularity to the irregularity. So what's happening in this rhythm is we still have a sinus rhythm because we have upright P waves, and we still have a P wave for every QRS, but these early beats that I've shown you by circling are happening every third beat. So this would be an example of a normal sinus rhythm with trigeminal PACs. So tri meaning 3, so every third beat, trigeminal. This rhythm here. Here again, if we'll take a look at if it's regular or irregular, those are the same, but then we see this is an early beat. So then we have a little pause after our early beat. And then we go back to regular. And then we've got this early beat here. So then when we look at our P waves, we're gonna say that these are sinus waves because we have a smooth upright waveform with a QRS immediately following it. Even here, there is a P wave, but it just looks a little different. But all of the rest of these look the same. And we're going to have a normal PR interval and QRS complex. I'm not going to measure those because by now you guys should be able to properly identify those. So with this rhythm, again, we have a normal sinus rhythm, but we want to look at the consistency of these PACs. And even in just this short strip, we can see that every fourth beat is early. So we have 1, 2, 3, fourth beat is early. 1, 2, 3, fourth beat is early. So this would be a normal sinus rhythm with quadrigeminal PACs. So quad meaning 4. With this rhythm down here, we're gonna identify what our rhythm or what our rate is. So I'm going to use the 1500 method, and I get about 26 or 27 small boxes for a heart rate of 58. You can see that we have P waves, that are immediately followed by QRS complexes. We have normal PR interval and QRS complex. So right now we're just going to ignore these two early beats here. And we can say that this patient is in sinus brady because they have sinus P waves, but they have a heart rate of lower than 60. So sinus brady. And then if we look at these two beats here, this is essentially two PACs, one right after the other. So we can call that paired PACs or couplets. And the reason we can say that those are PACs is because they're early beats. And then we take a look at the T waves here and notice that these look a little different and a little taller than our T waves here. So basically our P wave is buried within our T wave. This rhythm here, we're going to assess for regular or irregular. And it's pretty regular. So we're going to use our 1500 method to get our rate, which is 188. But when we assess our P wave, we can't really see a P wave. So this wave that you guys are seeing right here, this is actually the T wave. So the ventricular repolarization that's happening here. So because we don't have a P wave, we cannot have a PR interval. And so you want to specify that there is no PR interval. So you can either say none, or you can use this symbol of drawing a circle or a zero with a line through it. So make sure not to write zero, because zero is different than just not being present. And then our QRS complex, we got 0.08. So with this rhythm, because the P waves are hidden, we can't necessarily call it sinus because we can't see the morphology of it. So we're just going to say that it's hidden. But because we can't say that it's sinus, we can't say that this is a sinus tach or anything like that. But because it's regular and so fast, we can deduce that this is multifocal atrial tachycardia. You can just write MAT, M-A-T. With this rhythm here, we're going to check to see if we're regular or irregular. And we can clearly see that we're irregular. When looking at heart rate, because it's irregular, we can use the 6-second method. And we're just going to be focused right now on the ventricular rate. So I know that the quizzes that you guys are taking ask a lot about atrial rate and ventricular rate, but really we only care about ventricular rate because ventricular rate is what signifies or identifies what the patient's pulse is. So using the 6-second method, 1, 2, 3, 4, 5, 6, 7, 8, 9. So a rate of 90. And here we do not have any P waves because none of these are P waves. These are actually flutter waves. So we can just say that the P wave morphology is F or a flutter. Because there is no P wave, there cannot be a PR interval. So again, we can just write that 0 with a line through it. But we still can measure a QRS complex. And so we measured here 0.06 seconds. So this rhythm here is atrial flutter. And atrial flutter is going to be a very obvious rhythm to be able to identify because it has this well-known sawtooth pattern. So it looks like the end of a saw and all of the teeth. So it's going to be very jagged. Some may consider these bumps to look like shark fins. However you guys choose to look at it, but just be able to identify that these are flutter waves and not P waves. So because there's no P wave, you cannot have a PR interval. moving on to this rhythm, we can clearly see that this is an irregular rhythm because we've got this spacing here, and this part might look regular, but then it starts to speed up a little bit, and even these parts are all irregular. So we're going to say that this is irregular. Using the 6-second method, we get a heart rate of 170. And if we're looking at these beats, we cannot see any type of P wave. There is no P wave present. But sometimes you might see a little bit of a squiggle. And so we can say that those are fib waves. But you could also just say there is no P wave. Because there is no P wave, there cannot be a PR interval. So we'll just write the circle with the line through it. But we can still measure our QRS complex, which is around 0.08 seconds. So this rhythm is going to be atrial fibrillation. So atrial fibrillation, there is no organized atrial activity. It's very chaotic. So there is no actual atrial contraction going on. So you see no P waves. And then we can further specify and say that this is an uncontrolled AFib because the heart rate is above 100. So if the heart rate is above 100, we say that it's uncontrolled AFib. We have no control over the heart rate. If the heart rate is below 100, we'll say that that is controlled AFib. Now, AFib can be considered a bad rhythm. And it's a rhythm that cannot be ignored. Patients that are in AFib, we either need to try to work to correct that AFib or treat some of the symptoms that they have going on related to their AFib. And the reason that it's bad is because the atrium at no point, as I said, there's no organized atrial activity. So the atrium at no point are fully contracting. So there is no guarantee that the atrium is going to eject any blood. So that blood as a result can kind of just sit stagnant in the atrium or even just kind of form a swirling pattern but never actually go anywhere. And so as a result, the blood in the atrium, or more specifically the left atrial appendage, so a little area or sac that's hanging off the left atrium, the blood can accumulate in there and start to form a clot. And what happens with that clot is that if any point that clot becomes dislodged, it can move on to other areas. So if the clot was in the right atrium, it can leave the right atrium and head into the ventricle and then the pulmonary artery, and you can end up with a pulmonary embolism. Or if it was somewhere in the left atrium or the left atrial appendage and gets knocked loose for whatever reason, it can head into the left ventricle and be pumped out somewhere to the rest of the body. And the most common thing and most harmful thing that can happen is stroke. And things that can cause that the clot to become dislodged can be a variety of things. The first can be if they're in AFib and a clot forms and then they just spontaneously return to a normal sinus rhythm, and now we have that full atrial contraction, that can cause that clot to become dislodged. If the patient were to experience any trauma to the chest, whether they get punched in the chest or even a forceful cough, that can dislodge clot as well. And finally, if the patient were to have a cardioversion, so we're electrically shocking them to restore that normal rhythm, both the trauma and the blunt force of the shock and then the return of normal sinus rhythm, if it's successful, can also trigger the breaking off of that clot. So if we find that a patient is in AFib, usually the first thing the doctors will do is start some sort of blood thinner. A common one is warfarin or Coumadin. That's a very common one. So that's going to help thin the blood and reduce the chances of clotting while they try to figure out how to reverse the AFib. More specifically, with uncontrolled AFib, that's when patients especially can be very symptomatic because that heart rate is so fast that the body is not able to sustain a good cardiac output and good ejection fraction to get that blood out to the rest of the body. So the patient can sometimes have a little chest pain or even some shortness of breath. So sometimes the first step to treatment with AFib is not necessarily to reverse the AFib, but if they're in an uncontrolled, really fast AFib like this, to just reduce that heart rate to allow for better ventricular filling to increase that cardiac output. Moving on to the next rhythm. This is a good example of, Moving on to the next rhythm, this is a good example of a controlled AFib. So we can see that this rhythm is very irregular. And because this rhythm is slowed down, it's not as fast as the one that we just reviewed. We can see better how there is no organized atrial activity. So there is no contraction happening in the atrium and you can't see a P wave. So this is a really good example of a slower AFib. So in this example, the heart rate is 50 and we do not have a P wave, so we cannot have a PR interval, but we do have a QRS complex of 0.10. Considering all of this and how it meets the criteria, we can call this AFib, but because the heart rate is less than 100, we can say that this is controlled AFib. I'm going to skip forward to cover one that we haven't covered yet. So this one down here. So if we want to look at this in terms of regular versus irregular, we can say that it's pretty regular. Again, here it's just off by a box, still just off by a box. So this is a relatively regular rhythm. And we can say that the heart rate is 68. But when we look at the P waves, we notice that the P waves change shape. So here it starts nice and upright, and then it just kind of starts to get a little smaller and a little flatter. Here you really don't see much of one at all. Here it's non-existent, and here it's pointing down. So this is considered an inverted P wave. So we can say that this is a variable P wave morphology. They're all looking different. And we can also say that the PR interval is variable as well, because in some areas you're not going to be able to measure it. So you won't be able to measure a P wave here. This one, because it's so small, it's going to be difficult to measure. And then the other ones where we do see a P wave, the interval is probably going to be a little different because the impulse is coming from other areas in the atrium besides the sinus node. So we can just say that the PR interval is variable. Our QRS complex, though, should be somewhere around 0.06. 0.06. You probably even measured a little wider, and that's okay. So when we have a regular rhythm with a heart rate of 68, with variable P waves, this is what's considered to be the wandering atrial pacemaker. So what you'll notice when looking at the criteria is that the criteria for multifocal atrial tachycardia and wandering atrial pacemaker have very similar criteria. They're exactly the same except for the heart rate. So basically, a patient can be in this wandering atrial pacemaker, and if their heart rate goes up, or if their heart rate is greater than 100, then it becomes multifocal atrial tachycardia. Moving on to this rhythm down here. The biggest thing that I wanted to point out is that this rhythm, we can very clearly see these flutter waves, so this sawtooth pattern between the QRS complexes. But what I wanted to point out is the regularity. This is a very regular rhythm. So you can see that the space between the QRS complexes are all the same. And so we want to identify the ventricular heart rate. So measuring the space between the QRS, which gives us a rate of 79. We'll say that our P waves, these are not P waves, but flutter waves. So that's the morphology of these waves here. But there is no PR interval. We have a QRS complex. So we can say that this is atrial flutter, but because it's regular, we can count the number of F waves and compare them to the number of QRS complexes and list it as a ratio. So for this one, because it's regular, we can say that it is a 3. We can say that this is a 3-to-1 flutter because there are 3 flutter waves to every 1 QRS. So 1, 2, 3, QRS. 1, 2, 3, QRS.